Good evening, everyone, and welcome to the Omega Psi Phi Fraternity Second District Health and Wellness Monthly Webinar. I will be your moderator for the evening. I am Dr. Keith Boykin, and I would like to welcome everyone to this program tonight. The opinions and views expressed on this program tonight will be those of the brothers individually and not the opinion of the Omega Psi Phi Fraternity. We have a very good program set up for you tonight, one that's timely, that everyone is probably going to be very aware of. But we got some interesting information for you and a special treat for you. So without further ado, I'm going to turn it over to Brother Dr. Jedan Phillips as our chairman to give his open remarks.
Well, good evening, everybody. Good evening, my brother, Dr. Boykin. Always good to see you, sir. Thank you for, as usual, stepping in and being our moderator for the evening. Again, this is another chapter of our preventive health discussion series where we are discussing issues that are relevant in our community that are preventable, and having this information can be helpful in improving health outcomes. Tonight, we're going to be talking about what is the theme for October, which is Breast Cancer Awareness Month. Breast cancer affects Black women at a higher rate as far as causing death. You know, Black women have a 40% higher breast cancer death rate. In addition to that, we also see the more aggressive types of breast cancer happening disproportionately in women of color. In addition to that, you know, as we've seen with other medical conditions that involve preventive testing, we have seen that we don't take full advantage of these preventive testing, which include mammograms and ultrasounds as a couple of the tests. So tonight we're going to be talking about breast cancer awareness, what you need to know, and we're going to have an additional treat as far as an additional special guest to join our discussion. So again, thank you everyone for joining us tonight, and we look forward to having a great dialogue with you.
Thank you, Dr. Phillips. And at this point in time, we're going to have each of our brother physicians introduce themselves briefly, and then we'll get on with our program. So I'll start out with Brother Wingfield. You give us your introduction tonight briefly.
Hi, good evening. Thank you once again. It's an honor and a privilege to be here speaking regarding breast cancer awareness. Obviously, October is the Breast Cancer Awareness Month. So very excited to be here to discuss this topic. I am Dr. Edward Wingfield. I'm an interventional cardiologist practicing once again in New Jersey. What I would like to bring to this dialogue this evening is the cardiac concerns when it comes to cancer treatment and breast cancer treatment. It is the entity of breast cancer, but cardiac disease always plays a role. So certainly I'm going to highlight some of the concerns and what we need to look out for and what we need to know to best treat breast cancer, but also to address the other issues that come along, whether it's during or after chemotherapy or radiation treatment. So once again, honor, privilege to be here. Very excited to join into this dialogue. Looking forward to a little more.
Thank you, Dr. Wingfield. You know, you make a good point. Breast cancer involves everybody, both races, and a lot of ages. So we look forward to your information as well tonight. So I'm going to go ahead and move over to Dr. Plummer for our ladies out there, our OBGYN brother on the call.
Hi, good evening. I'm Dr. Christopher Plummer. I'm board certified in maternal fetal medicine and obstetrics and gynecology. This will be a great talk about breast cancer. I have, diagnosed a few, lumps and also breast cancer in some patients when I used to do a lot of gynecology. So it's something that I'm, familiar with. It'll be a great discussion amongst the brothers, and hopefully we'll learn some more new information. Thank you.
Thank you, Dr. Plummer. I know I haven't talked about Brother 95, but I have a reason for that tonight, brothers. I'm going to go ahead on to Brother Dr. Ford. Will you give us your introduction, please, sir?
Good evening, everybody. My name is Dr. Kelvin Ford. I'm an internal medicine physician, board certified internal medicine. I practice in Prince George's County, Maryland, Lanham, Maryland. And, my thrust has always been prevention. And hopefully we can come across to the audience things we can do, risk factors that can cause breast cancer, along with how you should be screened. So looking forward to the discussion this evening.
Thank you very much. And I forgot to introduce everybody that I am a pediatrician. We do have breast cancer in adolescent population as well. Now, without further ado, I saved him for last, Dr. Isabell, because Dr. Isabell is going to give us his introduction, and he's going to bring us our introduction to our special treat tonight.
Good evening. Once again, thank you for being here. I'm Dr. Lee Isabell, board certified internal medicine, HIV primary care, as well as hospital care. Breast cancer has affected probably everyone somewhat. They may have someone in their family that has contracted unfortunate breast cancer. Everyone may have a story. The special guest is my mother, Pamela Isabell. She's the matriarch of the Isabell family. I'm the second oldest of 8 children, and our mother is very dear to us. And I'd like to introduce my mother, Pamela Isabell, who's a cancer survivor.
Thank you so much. Welcome, Mrs. Isabell. So glad to have you here this evening. So we're just going to let you tell us about your story and, take as much time as you like, okay?
Thank you for inviting me, and thank you. God bless you. Thank you, my son. It's a blessing to be a part of this. My story begins back in 2004 when in January I had gone to the doctor. I had my mammo. Everything was fine. The doctor said I had the hormones of a teenager. I was fine. 3 months later, I went to the doctor because I was bleeding. And so when I went to the doctor, he was sending me for the ultrasound of my uterus and all of that. But before I got up, he said, "You know what, have a mammo." And I said, "I already had a mammo 3 months ago." "Oh, just have another mammo." And I believe it was God speaking to him, telling him to that something was going on. So I had my mammo. I didn't tell anybody about it because I was always being the caretaker of the family. So I wanted to protect. So I didn't say anything to my family. I had my mammo, and I could see something was there because they had me wait, and they took some more tests. And then when I got to the results of the test, they said I needed to have a mammo. I still didn't tell anybody. I said I had to have a biopsy. I said, "Oh, if it comes back negative, nobody needs to know," because I wanted to protect my family. And that's a mistake. You need to tell your family. So my friend, she took me, who's not here today, my dear friend Tony Bean, the judge, she took me, and I had my biopsy. It came back. Didn't say a word until I found out, but I couldn't. When the doctor called me and told me, I couldn't get in touch with her. So my daughter called me, Dr. Takoa Turner. She called me, and she was Isabell at the time, and she saw something was wrong. So I broke down, but I said, "I don't want anyone to know. I will handle it. I want to protect everybody." Well, she told all her siblings. She told her father, everybody. So I went to the doctor, to the surgeon, and I was like in a daze. I was really in a daze, and I couldn't believe this was happening to me. So therefore, I had a mastectomy, and then I had to go back and have my lymph nodes removed. Then I had to go back and have another surgery, and then I had the reconstruction. Then I had the port put in it. So I had chemo, and then I had radiation. Then I was on tamoxifen, and I passed that 5.5, 6 year mark. Then, doing that, I was so sick, I could not even get up. I was like, I was so sick, I was like in the bed, and I said, "God, if you get me up, I will give you the praise and the glory wherever I go." So I got up, because I had to take Neulaster after each treatment too, and that just knocked me out. So therefore, my quality of life was not really good then. And I made it through the 5.5, 6 years. Then I came down the second time. And the doctor told me then, there's nothing more we can do. And my kids did not take that. And my husband, they did not take that. They said, no, 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 no. So it was my son, Lee, that got me into Sloan Kettering. So I went to Sloan Kettering. I had another surgery because it had come back. When it came back again, it was underneath my arm. And it was on my nerve. It was on my blood vessel. So they said that there was nothing that, they could do. But Sloan Kettering, I had another surgery, which was a chance taking that surgery to remove that. And I went back. Should we put her on chemo again? Should we put her on radiation? So I had all of that. Then I went on another medication, which was Aromacin, and then Auristatin or something. I can't remember the exact name. But when I went through all of this, it was my children and my family and my friends that brought me through. And also I was part of a group I joined Sisters of Greater Long Island, who our founder was Linda Hart. And she was president at the time. And we were a group of women that came together that were going through breast cancer. So we supported each other. We lifted each other up. We raised money and to help other women that were going through breast cancer. I was one of the ones with Louise Jones that was able to write it. We got it as a 501c3, and we just helped and supported and lifted each other up. Yes, we may have gotten down sometimes, but we wouldn't let anyone stay down. We would encourage them and bring them up, bring them their spirits up. And it was a blessing to be a part of this group and also you have to stay positive. I stayed in the Word, I prayed, and that's what we did as a group. We prayed together and we lifted each other up. We did fundraisers, we did walks, and God has just truly blessed me. Then I went to live I went with my daughter in Nashville. Then I went to Vanderbilt, and I was still going through treatment there. And then I had joined a group down there called Sisters Network of Nashville. And there we lifted each other up. We prayed. We fundraised. We helped other women too going through breast cancer. And also in that Sisters Network Nashville, I helped, was one of the ones that helped get the 501c3 for there. But God has blessed me to help other women to speak and encourage other women that it doesn't have to be a death sentence, but we have to have early treatment and not be afraid to tell our families that we have to tell them, don't do what I did and try to keep it from my family at first. That I should not have done that. But as me, I was a caretaker. I took care of everybody. I took care of my parents when they were sick. I took care of the family. If someone needed a home, a place to stay, that was me. And I wasn't used to letting others, take care of me. That was hard. So therefore, we have to let our families know what's going on. And I didn't know that it was a history. There's 7 first cousins that have had breast cancer. 2 of them passed from it. I didn't know until I went the second time around that was on my mother's side. That on my father's side, my grandmother had it back in the 50s, and she was one of the ones that they experimented on with the mastectomy and all that. I did not know that until my father's first cousin, told me, because she said nobody talked about it. They kept it quiet. But I didn't know all that time, and that we have to let each other know, and we have to go for treatment and not be ashamed to speak about it, not be ashamed to share your story with anyone, because we can help each other. And that's what we have to do. We have to save our sisters, and we have to not be ashamed to speak about having breast cancer or going through breast cancer, because God will bring us through, but God heals us in his way and in his time. And our healing may not be the same as someone else's healing, but thank God I am here today through God's grace and mercy, through the love of my children, my husband, my family, and my friends. And I thank God because he has truly blessed me. Can you hear?
Take the mic. I'm sorry. Wow. We thank you so much. You said so many important things. I mean, I was taking notes as you were talking, because all of the things you said are the things that we as physicians try to promote out there every day. And I think the most important thing you said was the support of the family and telling someone. That's the most important thing. So we're going to jump right into it. A couple of things you said. You went through the process. You had your surgery, you had your mastectomy, you had chemo, and you had radiation, and you was on tamoxifen. That's kind of the standard of care now. So I'm going to ask Dr. Plummer, who is an obstetrician and gynecologist. Tell us a little bit about those aspects of breast cancer, Dr. Plummer, if you will.
Well, I mean, the first thing is, detection and screening. And also one of the things that is very important is to know your family history, because if they were known a strong family history of breast cancer, then the screening would be more appropriate, to that. But as I said, again, kudos to your gynecologist that saw the uterine bleeding to just say, let's just get another mammogram, because mammograms are not foolproof. They're not all 100%, and that detection was very, very early detection was very important. Tamoxifen is an anti-estrogen thing, is used for breast cancer that are like estrogen that have estrogen receptors. One of the things that it can cause is uterine bleeding. So one of the things we also want to follow is the uterus, just to also make sure they don't develop uterine cancer. But tamoxifen is one of the treatments. And also there's so many different modalities of treatment. It depends on what kind of cancer it is. It depends on how aggressive it is. Some people can just have a lumpectomy. Some people will have a mastectomy. Some people will have even a double mastectomy. And that's usually talked with their surgeon based on their history, based on the aggressiveness of the tumor. And obviously, if the tumor has gone outside, they will also check the lymph nodes, because if it has gone outside the lymph nodes, then that also will cater to the cancer treatment.
Wow. So, thank you very much, Dr. Plummer. You are our OBGYN, and Mrs. Isabell's physician was an OBGYN, but it's not necessarily limited to OBGYN and obstetricians, because primary care physicians are somewhat, in the forefront of all of that. So I'm going to just open up the floor now to either Dr. Phillips, Dr. Isabell himself, or Dr. Ford, talk about, as primary care physicians, your role in detection and help prevent that. And then I'll come back to Dr. Wingfield later on and talk about some aspects in his field as a cardiologist. So why don't y'all just take that and tell us about how you as a primary care are involved in this?
Well, firstly, I just want to say thank you, Miss Isabell. We truly, truly appreciate. And again, God bless you. Remind me of my mother. She's got 6 kids. You got 8. But, we will go to war for her. And I think my first point I'm going to make is related to that, because one of the things that you see with cancers and these other conditions is that we don't always get the more current and more sophisticated treatment. So God bless your son, Lee, for pushing you, because unfortunately, many individuals will accept that there's nothing we can do. And then we see what contributes to the high level of mortality and morbidity in Black women. As far as me as a primary care physician, two ways that I engage this moment. One is through my annual exams. So in me doing my annual exam, part of it is me making sure that a woman is up to date with her preventive care, recommendations, starting at the age of 40, making sure that you are getting your mammogram. Again, if they are experiencing any of the symptoms that we get concerned about, I picked up a lump, I'm having pain, I notice discharge or bleeding from my nipple, all of those things can be problematic and cause us to be more aggressive or send the patient in to be evaluated. So there's two scenarios that I normally will encounter this. One, like I said, is my annual exam when a patient comes in. And then you may get patients that have a family history, like you mentioned, where they, because another thing that we've talked about over the years in this space is, unfortunately, as a people, we don't talk about what's going on. So you may have individuals that have a history, as you mentioned, having 8 relatives that have breast cancer. That is something that would prompt us to do genetic testing or other types of more invasive testing to see if there's a problem, much more than what we would normally do, where we would just send for a mammogram. But those are a couple ways that I will engage a patient as far as evaluation. I'll yield to Dr. Ford and Dr. Isabell at this time.
I think just like Dr. Phillips said, getting your patient in on their annual exams, but also you want to basically, when they come in, just try to assess their risk, right? Are they an average risk? Are they a high risk, right, for breast cancer? Because that will determine how you're going to actually screen patients, okay? Now, average risk patients, when we say average, they don't have a high risk. That's usually you get them a regular mammogram, a 3D mammogram. Somebody that is at high risk, someone that has a strong family history of breast cancer, they have something we call BRCA genes, right? Someone who has had radiation to their chest before, right? When they're younger, they're at higher risk of having breast cancer. Or someone who themselves has already had a breast cancer or been tested for BRCA genes. Those people you test, they don't just get the mammogram, they get the mammogram and they get an MRI of their breast, right? And so, that's so you really want to assess what the patient's risk is. And so I think we can go into, those are some of the high risk people that I just mentioned. And then also when you're going to test them, right? So we know that there's certain societies have different ages in which you're going to test, right? But I think the standard, most people will say you want to start testing at 40. Now, those high risk people that have BRCA genes and need to get the MRI, they need a little bit earlier. They need it at 30. Okay, you start testing them a lot earlier. And so, depending on whether they're average risk, high risk, will determine when you're going to test them and how you're going to test them. So I'll let Dr. Isabell kind of go from there.
Thank you, Mom. Regarding primary care breast cancer, similar to any other primary care physician, we do annual screening, or we have a lot of primary, we call electronic medical records. They may have this preventive and alert. The way if a patient doesn't have an updated mammogram, it helps to remind the doctor. So that comes handy. Me personally, I have some patients that may younger than the normal age or atypical presentation. For example, a patient who was being treated for a rash like cellulitis, she kept getting a rash and they told her, oh, that's just eczema. But it was a form of cancer, Paget's disease. Mm. And she thanked me for sending her for the test, mammogram, and even referring her to a breast specialist, because everyone's saying, oh, you're too young. This is just an infection or a skin rash. Just give a topical steroid cream. So primary care, there's a lot of atypical. And one thing that affects a lot of Blacks, 10 to 15% more, is triple negative. What's triple negative? That's when you don't have any of the hormones that the estrogen, the progesterone, or the HER2. That all could be negative. You could either have high protein or low protein. The problem is it's aggressive and high rate of is death. Not much treatment, but we have, except there's immune therapy that they have known to help in triple negative treatment. And what I'm saying is, like my mother said, let every family member know, because you may not know that one person who may know of a treatment that you did never heard of, or can help get you treated. Or so I've seen other patients, or even where they said there's nothing we can do, and they talk you, let's do palliative care, let's do hospice. Yes, some of the stuff may be investigation if that failed, but never give up, fight to the end. So primary care is very important, because I think of primary care a lot as the gatekeepers of everything. Thank you.
Yeah, I appreciate that. And I appreciate you, Mrs. Isabell. You can stay on as long as you like. But, I thank God for your son that, took it a step further, because we need more family members like that. But he also mentioned a very good point out there. I don't know if a lot of people picked up on it, but investigational. More of us need to get involved in investigation and studies, because if not enough of us are getting involved in these studies, we don't have any data on our own people. We have data on the other people that we try to extrapolate back to our own people. So, I appreciate you very much for coming on tonight and telling us your story. And the part that you talked about being an advocate, joining groups, this is what we need to do as a community. We need to have our support groups out there. And the fact that you left New York and went to Nashville, Tennessee, you didn't stop, being a support for others. I am most appreciative of you for doing that, because I am a surviving cancer patient myself. So I know exactly some of the feelings that people are going through. So I really, really appreciate you coming on here and talking to us tonight. I didn't forget you, Dr. Wingfield. And she talked about one part of this, her treatment process was a mastectomy. And we know that mastectomy and radiation itself are not just benign things that undergo. You may have some consequences from that, some post-operative consequences, or you may have some radiation consequences. You mentioned earlier that you wanted to speak about how they could affect your specialty of cardiology when you've had mastectomy or radiation, something like this. So, the floor is yours, Doc.
Thank you. And Mrs. Isabell, thank you so much for sharing your story. It is just vital. And I know in the beginning, it's very difficult. It is very difficult to tell people, because of the reaction that you're going to get. And it's just the coping with what you've found out. But there is so much in terms of therapy for breast cancer and all of the cancers, but early detection, early awareness is super important. And one thing we see from a heart standpoint is that, as we all know, heart disease is the #1 killer in the United States and throughout the world. But when you're diagnosed with cancer, that becomes the focus. However, heart disease remains part of the focus. In fact, there's specialties now called cardio oncologists, where you have cardiologists who actually treat patients, cancer patients, because of issues with radiation, issues with chemotherapeutic agents. So the things that we look at from a cardiac standpoint is, in a lot of cases, I will see a patient prior to starting their chemotherapy to get a baseline echocardiogram. We want to know what your heart function is before you start your chemotherapy. We want to know your history of chemotherapy. Did you get treated for lymphoma? Were you treated for another cancer? Then that's going to dictate how much chemotherapy you can receive, right? What was the duration? How many cycles did you receive? Because at certain levels, those medications can certainly become toxic. What type of cancer? Was it a left-sided breast cancer versus a right-sided breast cancer? That's going to tell me, did you get radiation to the left breast versus the right? Because radiation causes an increase in ischemic heart disease, where the blood vessels that supply blood to the heart can become stenosed or narrowed from radiation treatment. And typically this is 10 years down the line. So your cardiologist is going to be in tune with those things. And we want to make sure that you receive a stress test, and all of these things continue to happen. And we've already established the baseline. Some of those chemotherapeutic agents lower your estrogen. So they're anti-estrogen agents. And we know estrogen is protective to the heart. Women have a protective advantage over men until they reach menopause because of estrogen, right? So it reduces your risk of heart disease. But some of these agents lower that estrogen level and will actually put you as equal risk to men. So there are many others, and some of the chemo agents can trigger hypertension and raise your cholesterol. So we certainly want to know what agents you're on. Although the focus becomes breast cancer and treatment and radiation and surgery and all those things, we also still want to keep in the periphery a relationship with your cardiologist, because at the end of the day, once the cancer is treated, the overall risk of heart disease still outweighs the risk of the breast cancer. And again, thanks for the story. And we're very appreciative to have you here.
I think we just thought he was a cardiologist, guys. He's talking about chemotherapy things. We thought he's just a cardiologist. Good job, brother. But Dr. Phillips, you had something you wanted to say?
Yeah, I think another thing to add on is the critical nature of mental health wellness, because she talked about how friends and family sort of stepped up at moments where you could have said, you know what, I'm going to accept what these people are saying. And I think, again, that speaks to how important that is as far as that mental health wellness and having that supportive village and being open to that. I think too many times, and we had last month, our guests discuss the mental health aspects of prostate cancer treatment and having prostate cancer. As you mentioned earlier, once you heard the C word, how did that affect you? Were you able to make decisions at that moment? Did you need somebody there to help you? All of these different things are very real, and they need to be factored in, because unfortunately, there are many individuals that don't have a son named Lee who's not going to accept no for an answer.
Right.
And unfortunately, as we said earlier, we might not have a friend like your friend, Tony, that said, I'm coming to get you, girl. I don't care what you say. You know, that type of support and village really makes a big difference, you know, as far as a person's ability to bounce back. Because I'm sure as you were going through the physical changes associated with the treatment, to get to where you are right now took a little work and took a little faith.
Amen.
Thank you, Dr. Phillips. And now you talked about you went back in your generations a little bit, Ms. Isabell, about your in your family members. And as a pediatrician, I get involved in a kind of a different aspect of it. Were there any young people in your family, say adolescents, that had early breast lumps or anything like that? Do you recall anyone in your family that had that?
One of my daughters had to have a biopsy of hers when she was in her last year of college, right before finals.
Okay, because sometimes as a pediatrician, we have young ladies come in, and it's difficult for them because, as you say, they don't think about the C word, but they'll notice something. They'll have a hardness or something on their breast, and first person they're going to come to see is a pediatrician. So, we got to determine, what is this? Is it something we call fibroadenoma, which is a benign disease of the breast, or is it something to be more concerned about? And what we haven't mentioned tonight is that what do we do when we make the diagnosis? But before I get to that point, I have to say that, in kids, we have to figure out what it is. So we mostly get an ultrasound to see if it's a fibroadenoma or what. We also want to look at that around their cycles, their menstrual cycles, because that makes a difference in terms of lumps and things like that as well. So, but if we have something suspicious, then the first thing that I'm going to do as a pediatrician primary care person is refer them to a surgeon, because surgeons by and large take care of the cancers mostly than anything. You had a very great obstetrician, a gynecologist that took that role and ran with it. But lots of times people don't understand, what do I do now? My doctor said I got a lump. I need to have a mammogram. They found something on my mammogram. What if it's positive? What do I do? And things like that. So a surgeon is what we go to next in that aspect of it. So, but anyway, I just want to bring it up. And the other aspect of it is 99% of all breast cancer in the United States are women, but there's 1% are men. Men can have breast cancers as well. And unfortunately, we don't have the technology and the screening process in men that we have for women. So, there's a lot of, what's the guy's name, the actor that plays Shaft, Richard Roundtree, a survivor of male breast cancer. So breast cancer is not just restricted to the females out there, but men as well. So, but anyway, I wanted to bring it back that who was I think it was Dr. Wingfield said the estrogen effects, because men don't have estrogen enough to be determined about that aspect of cancer. That triggered my little thought process on that. But I want to go back to Dr. Plummer again. Now, you as a gynecologist, you made the diagnosis, you referred to a surgeon. What is your role after that point in time in dealing with all of that?
Well, first we, referral, and then after they do the treatment and then the chemo, then there's usually then a follow-up. Now I specialize mostly in obstetrics and also in maternal fetal medicine, and that is also an aspect. When you're pregnant, pregnant women also can develop breast cancer, although it's a lower incidence, but it is something that is important. And women need to understand their body and know their breasts, because they sometimes will be the ones to notice that there's something irregular or something that is wrong, and then they need to go to their doctor. And if their doctor is really not understanding that they're feeling something different, then she should probably be referred to a breast surgeon. And also, when you are diagnosed with breast cancer and you are pregnant, there are some chemotherapies that you can be given in pregnancy, just in consultation with your high-risk pregnancy doctor and also your oncologist. So I just don't want to think just you got, breast cancer that, I can't be treated for this breast cancer while I'm pregnant, and then it could go to advanced stages by the time you complete the pregnancy. So those are what, important things that I just wanted to make them aware of. So,
simultaneously we have, we've referred to the breast, we've referred to the surgeon. But before we get to that point, what do we try to do? What do we try to talk about? What do we try to bring up, interrelated diseases? Say, for instance, you have someone with hypertension. You have someone, you said, Dr. Wynn, for heart disease. And we know now they've got a positive mammogram and they need to go. What do we do? How do we direct those people? What do they need to do now to prevent further disease? Anybody take that question?
Yeah, I think in terms of knowing the therapy and what type of therapy they're going to receive, obviously, if you have hypertension, if you have diabetes, these risk factors are going to increase your overall risk, right? So those comorbidities is going to put you at a higher risk of a poor outcome. So certainly you want to make sure that the diabetes is controlled and the blood pressure is controlled, because, as I said, some of these chemotherapeutic agents will raise your cholesterol, will raise your blood pressure. So we want to make sure that those issues are addressed. So it is a coordinated approach. Okay, so interdisciplinary approach with your primary care physician, your oncologist, your surgeon, your cardiologist, and obviously all of these physicians should be communicating with one another. And I think that's extremely important in sharing the overall treatment summary, right? How much treatment did you get over the lifespan of the cancer therapy? So open communication, addressing those risk factors, not smoking, continuing to exercise. So those things are going to really increase your chance of survival and improving your overall outcome.
And you might want to even add on a mental health specialist, because again, that type of counseling makes a difference. I think just highlighting what Lee did, Dr. Isabell did for his mom, that advocacy, and I say that as a primary care physician, along with Dr. Ford and Dr. Isabell, we've got to push them. We've got to get them into a space where they become aware of the most current treatments. Because unfortunately, not only in breast cancer, but in many forms of cancer and other medical ailments, we see that we don't, and I say we meaning people of color, even when they have good insurance, are not directed to the cutting edge therapies. So having a point guard, a quarterback, a primary care physician that is taking all of that information in and making sure that they push you. I think I had a patient recently that was starting treatment for cancer, and I had to send them to the cardiologist to optimize their cardiac health prior to starting the treatments, because the treatments would have had a negative effect on her because of her cardiac situation not being stable.
So let's take that point and run with it, Dr. Phillips. Advocacy. You stole my thought. I was going to come back to Dr. Isabell, because Dr. Isabell has to me a dual role here as an advocate. He was an advocate for his mom. He was an advocate because he's a physician, and he's a minority physician. Knows that the advocacy is how important it is to get people pushed on. When they told her there's nothing more we can do, he became her advocate, probably as her son and as a physician with knowledge. So you want to speak a little bit about the advocacy from your point of view, Dr. Isabell? How you did it with your mom, come off mute.
So how did with my mom regarding her cancer. So even being a physician, you've always have to learn. You have to do your research too to know what the latest treatments are. So to do that, I helped advocate for my mother, and I was familiar with how oncologist groups like Sloan Kettering, so that they have the latest technology. I'm not promoting any organization. You just want you send to who has the latest and the best, and that's for any patient that I take. Minorities, a lot of times I see they may not know the latest treatments, or it's not being pushed by even my colleagues. So that's diversity things that has to change. Also, a lot of times I see with advocacy regarding when patients, some are diagnosed with cancer, they aren't aware that if you have diabetes, hypertension, sometimes the medications blood pressure have to be adjusted, because either it can make your blood pressure lower or it could be high. Also, being a diabetic, sometimes they give a lot of these medications, some with steroids, so your sugars can go out of control. Or example, if you're not eating your insulin, and you can get hypoglycemic. So what Dr. Wingfield said, I think primary care physician being informed. Sometimes patients disappear. They get their treatment for cancer, and they forget to follow up about their other medical problems until they have complications, or I see them in the hospital. And that's advocacy to continue primary care.
Very good point. Very good point. Because I think the biggest issue I have with the advocacy point is that, many times our community don't know where to go, what to do, how do we access, there's a strong family history of breast cancer. Now I found a lump. What do I do? How do I get into the system? Do I have the funds or the means to get into the system? But I think as physicians, we know how to direct people where they need to go. But we also need to educate the families and tell them that there's help out there for them somewhere, and that there's never a case where because you have a lump in your breast, or you have something wrong, you have a lump in your breast, and you have diabetes, you have hypertension, that you can't go seek healthcare, because healthcare is out there for everybody. And I'm just so proud as a physician, and my brothers and my colleague, Ms. Isabell, talking about how you can access care. Don't hold it in. As she said, don't hold it into yourself. Tell somebody about it, because, you know, you never know. Somebody that you know, your best friend, somebody like that, maybe it points you in the direction to get some care somewhere along the way. So I really appreciate all of that. So we're kind of getting to the top of the hour. We don't have much time, a whole lot more time left. Mrs. Isabell, I'm going to give you the opportunity to say any parting words you would like for our audience to hear from you, and what recommendations you would tell people in the future.
I would tell them that in the future, just make sure that you examine yourself every month, whether it's around your period time. If you don't have your period around the time you did, just do self-breast examinations. And if you, if one doctor doesn't help you or is sensitive to how you're feeling about your body, because you know your body, then go to another doctor. Don't stop and don't ever give up, because God has the last word. So don't ever give up. And there's doctors out there that can help you. And with your family also, let them know that, and be open to receive the help. Yes, we are caregivers. As Black women, we are caregivers. But there comes a time that we need someone to help and take care of us. And I guess what I'm saying is you have to allow that and accept that. And it does not make you weak or anything. It just makes you, there's a season for all of us, a season to help and a season that we need help. So I just want to say, go out there and be an advocate for yourself. Don't give up. Stay in the word.
Mm-hmm.
Stay positive. Lift each other up, and always be there as sisters, lifting each other up. And know that God always makes a way.
Thank you so very much. Thank you so very much. Thank you so very much. So at this time, we're going to have each of our brothers give out their closing remarks and anything they want to tell our community about breast cancer awareness and advocacy. So we'll start with you, Dr. Ford. Why don't you give us your closing remarks, please, sir?
Yes, thank you. And thank you again, Ms. Isabell, for participating and giving us your story. I think one of the things that even came out is that it's so important. Sometimes you may have to have someone come to your doctor's appointment with you, because if you get the results, you don't really even understand everything. And so having that advocate, whether it's a spouse or children or a good friend, I think that helps to make sure that you get all the information and understand all the information that was given to you. I just want to make sure that everybody gets their mammograms, make sure that you, and also men, to make sure that you're aware that we can get breast cancer also. And so just wanted to yield my time. Thank you.
Thank you, Dr. Ford. Dr. Plummer, give us your closing remarks, please, sir.
It was a great discussion today. Am I on the screen? Okay. It's a great discussion that we had today. The most important thing I want to make sure is that that they get the screening, that women are aware of their breasts, and if there are any changes or anything that doesn't feel right, they let their provider know, and also get evaluated by a breast surgeon. Also, if you do happen to have the diagnosis of cancer, that you sometimes will go to a cancer specialist or a cancer institution which has more research studies available, and also investigative trials that you can also get involved in. Those are also important things, and it was a very good discussion. And thank you again, Mrs. Isabell.
Thank you, Dr. Plummer. Dr. Isabell, I'm going to have you go ahead and give your closing remarks and whatever things you want to tell us as a physician and as a son of a survivor. Go ahead, Dr. Isabell.
As a son of survivor, it's different. It's fear that you're going to lose a loved one, fear that you're going to lose your mom. My mom may not be here, especially it was fear the second time she had cancer. So I think that's something naturally. So it made me an advocate. It helped me in my practice. I always complete, but to take breast cancer serious. Also, men can get breast cancer too. You hear that all the time, but there's some men who think that because they're a man, that they can't get breast cancer. And I'm sure there's a lot of men that still think that they can't get breast cancer. But if there's a family history on your mother's side, or if your mother has a high risk, if there's a family history of high risk of cancer, you also could be a high risk. If you're obese, or if high alcohol intake, that all increases risk. If you had prostate cancer, that increases your risk. If you were to receive, for example, some hormone replacement, a lot of Lupron. So in closing, get tested, go for your preventive tests. Always, if you have that diagnosis of breast cancer, family is very important, friend is very important, communication between all providers is very important. Thank you.
Thank you, Dr. Isabell. Dr. Wingfield, will you give us your closing remarks at this time, sir?
Thank you again. Thank you, Mrs. Isabell, again. Brothers of Omega Psi Phi, this was a wonderful exchange again. I'm always just so impressed with how this is done and the message that we get out. So I look forward to continuing this. As we always say, and we mean, early detection is everything. So we have to really stress that we need to be getting screened and having a relationship with our primary care physician. And once we are diagnosed with a cancer or any medical condition, we have to communicate that with our families because we save their lives as well. We have to become advocates and educators. So it is a baton that we have to pass once we do get that diagnosis. So as Ms. Isabell said, you have to advocate for yourself, ask your physicians questions, learn as much as you can about the disease process so that you can be informed, because that is going to dictate the way that your treatment goes. The more informed the patient is, the more involved the family is, that is going to increase the engagement of the physicians. So this is something we see on a daily basis. When the family's involved and the family's asking questions, things get done and we don't get pushed to the side. And then in closing, make sure we get a treatment summary so that we know what we received, what kind of radiation, what chemotherapeutic agents, because down the line, the heart always wins. So certainly want to make sure that we're doing everything we can while we're treated for breast cancer to also be mindful of heart disease. Thank you.
Thank you, Dr. Wingfield. And now I'll have Dr. Phillips give us his closing remarks, and then I'll come on and close the program out. So, Dr. Phillips, sir.
Good evening. And again, thank you, Mrs. Isabell, for your invaluable donation of time and your words tonight and sharing your story. It goes with our message that has been consistently month to month talking about the importance of prevention. As I've said many a time, prevention costs us a whole lot less than reaction does. I think the other thing that we learned tonight is you've got to be an advocate for yourself. And part of that advocacy is involving your team, and the team members can be your family. But as Dr. Wingfield just mentioned, if you have a primary care doctor, you've got to get them involved. You've got to let them know what's going on, because the treatment of cancer isn't just as simple as taking a medication. It can be a mental health treatment. It can involve physical therapy. It can involve supporting or providing paperwork to allow your family members to be present. But if you don't communicate that, then your primary care physician is not in a position to help you in the best way possible. So again, please take heed to the words that we are saying tonight. Please continue to log in with us on the last Wednesdays of the month as we continue to bring preventive medical messages to our community. And yet again, thank you to my other members of the presentation tonight for your contribution and your time. Thank you.
Well, thank you very much, doctors. And thank you again, Mrs. Isabell. Thank you very much for being a part of our program tonight. So I'd like to take this opportunity to thank our district representative, Brother Rico Gales, for allowing us to have this presentation, and all the other behind the scene people that are involved, and Brother Pearson, who makes this thing work for us every month. I forget to mention him every time, but I want to mention Brother Pearson makes this thing do what it does. So we are very much appreciative of you. So folks, you've heard it tonight. Breast cancer. We've come a long way, but we still have a long ways to go. We have to be advocates. We have to do early detection. We have to do self-examination. It is not limited to just women. Men can have breast cancer. You have to check yourselves too. And don't forget our daughters. Make sure they're checking themselves. And if they have any lump in their breast, they should not be afraid to tell their mother or their father about what's going on. So again, thank you for being here with us tonight. Please join us next month on the last Wednesday of every month when we do our presentations of our health and wellness. And don't forget to donate blood. There's a shortage there. But thank you very much, and we'll see you next time.